Good afternoon. Welcome to another George Consortium COVID-19 Public Health Law Briefing, presented by our colleagues around the country in association with the Public Health Law Watch at Northeastern University and the Center for Public Health Law Research at Temple University. We're here to provide you expert legal analysis during the COVID-19 pandemic and hopefully answer some of your questions. I'm Wendy Parmet, Professor of Law at Northeastern University, and joining me today are two true experts, really top folks on Medicaid. We have with us Nicole Huberfeld of Boston University School of Public Health and Law School, and Professor Sidney Watson at at St. Louis University. And we will be taking questions towards the end of this broadcast. Please ask them at Public Health Law Watch with /COVID Law Briefing. So really important, we know that Medicaid is always important to help in ensuring access to care for millions of Americans. But Nicole, maybe you could help us get started by talking a little bit about how Medicaid is enabling the states to cope with and respond to the emergency.
Thanks, Wendy. I'm glad to be here and thank you for having us. I just think it's really important for people to understand that as much as Medicaid plays an important role in people's everyday lives, it is also uniquely positioned to respond in a crisis, whatever the crisis might be, whether it's a natural disaster, a pandemic, a recession. In today's world, unfortunately, we're experiencing two of those. Medicaid is designed to be responsive to crises because it enables states to be flexible in a pandemic. And so the way that that happens primarily is with the stability of federal funding. The federal matching that's available in Medicaid has no cap. And there is a match formula that makes it so that roughly the amount that a state gets from the federal government is tied to the per capita income of that state, so that the poorer a state is, the more money it gets from the federal government. Because the federal government doesn't have to worry about a balanced budget, it can engage in what we call counter-cyclical spending, which means that in the very moment that people need Medicaid the most because they're losing jobs, in the very moment that state budgets are crashing because the tax base is crashing, the federal government can step in and offer more money, offer solidity and stability. So that counter-cyclical spending is a long-term feature of Medicaid that makes it so that Medicaid spending always goes up in a crisis and then comes back down when times are more normal. The other thing to understand about Medicaid is that it offers comprehensive coverage at little or no cost, including drugs, primary care, testing, all of the features of our basic care that we expect to be covered by any insurance program.
Sidney, is there anything you'd like to add to this?
Well, Nicole has talked about the financing part, which is critical. The other part to remember about Medicaid is it has a unique structure because it's designed to be a safety net program. Private insurance, commercial insurance, group insurance that many of us get through our employers, there's an enrollment period and it's once a year and you have to sign up during that enrollment period. That's not the way Medicaid works. It is there when people need it. People can sign up for Medicaid at any point or any time during the year. It also provides what's called point-in-time income eligibility, which means it looks at the income you have when you apply for coverage. So if you've lost a good job and now you're in need, you may be income eligible, and that's important. And finally, it has what's called retroactive eligibility. That eligibility starts up to 3 months before the day on which a person applies, if they're otherwise eligible. And that's really important because it means we can catch people and get them signed up for Medicaid when they show up at a site for testing, when they get sick and go to an urgent care center, or in the worst case scenario, end up in a hospital emergency room.
So you've been talking about Medicaid as if it's Medicaid, but we know that there are differences, right, between the states and particularly also between the so-called expansion states under the ACA that chose to expand their programs and there's many states that have chosen not to. Can you talk a little bit about what differences we might see between the expansion and non-expansion states?
Well, I think I'll start off on that one since I'm speaking from Missouri, a state that hasn't expanded. And I think the short version is that non-expansion states are entering this pandemic with one hand tied behind their back. By not expanding Medicaid, they cannot cover low-income adults who are not parents under Medicaid. And we know that that is about 2 million adults in this country as we started this process who states could make eligible for Medicaid and they haven't. And these are states like Missouri and Alabama and Georgia and Mississippi that are poor states. And I'm going to turn it over to Nicole to talk a little bit about who those people are who are left out.
So I think it's important to understand that in non-expansion states, if not all of them, then in most of them, there are deep economic disparities. People tend to work in agriculture, they work in retail, they're unlikely to have employment benefits like employer-sponsored health insurance, and many of them may not be making enough to even qualify for premium tax credits in the exchange to purchase their own private insurance, or if they could, they simply can't afford it. Even the tax credit that's available isn't enough to get them over that hump. So we see not only deep economic disparities in non-expansion states, but also more chronic diseases, more comorbidities, greater health disparities, and these things will inflame the impact of coronavirus, especially as we're seeing now in Black communities. We have the example that I learned from Sidney yesterday that in St. Louis, all of the deaths have been amongst the African American community. Today in the Boston Globe, there's reporting that 40% of infections are in people of color, even though they account for 25% of the population. And so I don't want us to be misconstrued as saying that Medicaid expansion is everything. Clearly it isn't, but it is such an important tool in the toolbox for battling a pandemic that without that tool, no state can address the problems that we're seeing right now completely. Also, we know that there are links between having Medicaid and being able to participate civically and politically. And so it means that people in these communities don't have as much of a voice as to how their state will respond to the problems that they're facing.
What difference does the fact that we're in emergency, and what I really mean here is that the federal government has declared in many different ways that there is a public health emergency now. Does that make a difference in terms of what is available in Medicaid, the tools that are available to states? Maybe Nicole, if you could start.
Yeah, thank you. So to be clear, if any of the non-expansion states wanted to expand Medicaid, they could do it at any time through a state plan amendment. It's a very simple process. It would be very quick. It would be very easy. And those states could also decide later on, if they didn't want to continue to engage in Medicaid expansion, that they want to withdraw that state plan amendment. Now, they would have to find places for people to go. But the point is, not everything requires federal government intervention. That being said, there are certain tools that are not available until the Secretary of the Department of Health and Human Services declares a public health emergency. At that time, once the Secretary has declared a public health emergency, he then has power to make certain grants, to modify telehealth rules, excuse me, to engage in contracts, to access emergency funds, and no state request is needed per se. In addition, there are certain statutes that require the president to declare an emergency. The Stafford Act and the National Emergencies Act both require that the president take action to ensure that, for example, FEMA can then kick into action, and that makes certain funding available so that states can make requests of the federal government. In combination, the Secretary's Public Health Emergency Declaration and the President's Declaration of an Emergency make it so that waivers that are called 1135 waivers are available.
Sidney, do you have anything to add? Maybe you could talk a little bit more about what is an 1135 waiver and how is it relevant to the present moment?
Yeah, I'd like to talk about it in two ways. we talk a lot about waivers in Medicaid. We don't talk a lot about a Section 1135 waivers because they are triggered when both the President declares an emergency and the Secretary of HHS declares a public health emergency. States like Florida and Texas have a lot of experience using these Section 1135 waivers to respond to hurricanes. Here in Missouri, we use them to respond to a tornado in Joplin. Now we see 49 states have 1135 waivers, which are allowing them to use Medicaid to respond very quickly to support the health system and to support low-income patients. On the provider side, it allows states to bring new providers into Medicaid very quickly, to bring in providers from other states to help out when needed. It also allows the use of telehealth, and it also allows some special rules to help patients keep their care, to remove prior approval authority for drugs and for ongoing services. So these emergency waivers are really important. They're short-term waivers. They are only good for 60 days unless we approved by the Secretary, and they go away if the public health emergency is retracted. So we have to realize that we're in a time where there are some special tools in Medicaid that are tied to these declarations of emergency.
Maybe you could talk a little bit about the legislation. Congress has passed several acts in the last few weeks responding to COVID-19. Anything in this legislation that impacts Medicaid, or I'll say more generally, healthcare access for low-income people, for the people in the Medicaid population?
Well, I'll take that one first. And the biggest news with Medicaid is that Congress has authorized a 6.2% increase in federal matching funds for Medicaid. This is not unusual in an economic crisis or a public health crisis because we know that the rolls go up when times are bad. One of the typical tools in the toolkit that Congress uses is to raise the federal percentage.